My chosen topic for this project is the treatment of opioid addictions. This presentation will discuss why opioid addiction is so prevalent and the benefits and deficits of current treatment options. I will also address what needs to be done to combat the opioid crisis and what the future may hold for prescription drug pain management. First, I will specify what the term opioids includes. Opioids refers to a broad range of pain-relieving substances that act upon the opioid receptors in brain cells, causing a reduced perception of pain and an increased sense of pleasure. Substances in this category range from prescription drugs such as hydrocodone and fentanyl to street drugs such as heroin. First, I will specify what there's a reason opioid addiction is being called an epidemic in the United States. More than 2 million people are currently afflicted with this illness. As you can see from the infographic, the United States consumes 80% of the global supply of opioids. In 2011, overdose deaths from prescription opioids were more than the deaths from heroin and cocaine combined. So why are we facing such an opioid epidemic? The answer is overprescription. Between 1999 and 2014, opioid prescriptions increased fourfold. Physicians were prescribing opioids in massive amounts before its addictive effects were well known. Therefore, opioids were widely available and all too easy to obtain, giving people a steady supply to feed their addiction. Opioid abuse and opioid addiction are not synonymous. Abuse refers to regular use of the drug without the effects of tolerance and physical dependence. When your body becomes physically dependent on opioids and experiences withdrawal symptoms without it, abuse has turned into addiction. Since a physical dependence has not developed in opioid abuse, treatment can focus on outpatient behavioral therapy and the development of alternative coping mechanisms. Addiction, however, is a mental and physical disorder that will require long-term treatment and maintenance. Addiction treatment requires detoxification and management of withdrawal symptoms, as well as a lifelong struggle to fight cravings and relapse. When a patient begins treatment, the first step is detoxification. This is almost always in an inpatient setting, depending on the severity of withdrawal. Constant monitoring of the patient's status is important due to the patient's possibility of extreme hypertension, dehydration, hallucinations, and even seizures. Along with nursing cares to promote comfort in this time, there are also several medications to make the process more bearable. A popular drug used during detoxification is methadone. Methadone is an opioid agonist, meaning that it activates opioid receptors. This activation, unlike with other opioids, does not create the desired euphoric effect. This helps make withdrawal more manageable by decreasing cravings. Patients are slowly tapered down on dosage until they can go off methadone without serious withdrawal symptoms. Naltrexone has the opposite effect of methadone. It is an opioid antagonist, which removes all opioid agonists from their receptors. This causes abrupt withdrawal symptoms to occur and is a commonly used medication in what is called rapid detoxification. Because of the rapid removal of opioid agonists from their receptors, withdrawal symptoms appear quickly and severely, so naltrexone is often given with sedatives. Clonidine is a unique medication. Its primary use is to treat hypertension. However, it also has an analgesic and sedative effect on the central nervous system. Because of this, it is a popular medication used in treating the physical withdrawal symptoms of detoxification, including pain and anxiety. Studies show that successful detoxification is much more probable with the tapered use of an opioid agonist such as methadone. Individuals on these medications are more likely to complete a detoxification program than those who are not. However, the slowly tapered dosing schedule can take several months in long-term opioid users, which is one critical barrier to sustained sobriety. After a patient has been detoxified and withdrawal symptoms are under control, maintenance therapy then begins. Continuation of pharmacologic treatment as well as other support therapies can now begin. In this stage, support and continuous access to resources are vital to a successful recovery. The use of methadone has been shown to produce more positive outcomes for patients. Being able to control their cravings leads to lower rates of addicts seeking out illicit opioids, thus reducing criminal activity, new bloodborne infections from IV needle use, and deaths from overdoses. The use of medications such as methadone and clonidine alone will rarely lead to sustained sobriety. Counseling services to guide lifestyle changes should be used as an adjunct treatment. Unfortunately, access to mental health services in the United States is a huge barrier to treatment. Costs and insufficient resources keep many patients from reaching their full potential. Drug rehabilitation services are available for different stages of maintenance therapy. Inpatient rehab either occurs with or directly follows detoxification. It offers 24-hour supervision and support and can manage other medical issues at the same time. Outpatient therapy can continue after the acute rehabilitation stage. It focuses on providing a support system through support groups and group therapy sessions and can last several years or decades. The road to recovery isn't as simple as medications and counseling. Each individual requires unique treatment needs. Three of these considerations include mental health needs, pain management, and treatment of other illnesses. Recovering opioid addicts often have other mental health needs than addiction treatment. Experiences during drug use can lead to PTSD and guilt over their own actions. Changes in brain chemistry from long-term opioid use can lead to mental disorders after cessation of opioids, such as depression and anxiety. Over one-third of patients on maintenance therapy are estimated to have moderate to severe chronic pain. Tolerance to analgesics in this population make pain management complicated. Because of this, non-pharmacological pain management should be explored, and the effectiveness of maintenance medication should be continuously monitored. IV needle drug use puts its users at an increased risk of acquiring infections. Patients with a known history of needle use should be screened for HIV, hepatitis, and other diseases caused by contact with blood. Long-term maintenance care involves a variety of intervention. Counseling and support should always be made available to the patient. Urine testing may be required for a period of time. And education on the dangers of relapse and overdosing due to lower tolerance should be implemented. Narcan may be offered at this time. Opioid addiction treatment needs to be individualized and collaborative. Limited access to recovery services is a giant barrier that needs to be overcome in order to promote positive outcomes for these patients and to control the opioid epidemic currently at hand.